guys get questions, I don't mind being interactive, didactic, ask questions, bring out cases. It doesn't have to be all me talking. So the talk objectives today is let's talk about the rationale for realigning fractures and dislocations in the field. Why should we do this as first responders, as being out in the backcountry? Is there a real rationale for it? What is the best in pre-hospital care? Then I'm going to go over the principles of managing fractures and dislocations in the field. We're going to give a few cases, just some cases that went well and some cases that didn't go so well. And then, how do you implement it? Whether it be paramedics, visitor safety specialists, on your hill ski patrollers, how do you get some of these things implemented? So, when I'm talking about the rationale, I think after the next 5-10 minutes, I'm going to convince you that it's a good thing to at least attempt realignment in the field. And people have a picture of reduction, the word reduction, as meaning perfect. That when you're going to straighten something in the field, it's absolutely perfect on x-ray, and that's the definitive care. It really isn't. It really is get things back to a relatively normal position. So that's why I like the word realignment as opposed to reduction. We're going to talk about the skin, the neurovascular bundle, soft tissue envelope, actual bone, joints. Pain is a big one, and then hemorrhage. All rationales for realigning in the field. So this is a case that we had in our emergency department, a couple of winters ago. Someone slipped in the parking lot in Nakiska in their runners, and they came in after about 90 minutes with this picture. And I don't want to see this picture in the emerge department. You can already see skin necrosis and breakdown. That is not abrasion. That is actual tenting of the skin over the medial malleolus, and that skin is dying. Not only is it going to cause troubles for me going in and operating on it, I don't want to operate through dead skin. It's going to cause some long-term sequelae, increased chance of infection, just all the bad things. So we don't want to see this. Get this image in your head and go, okay, this is a bad thing. So, tenting of skin over the deformity, local ischemia. It actually stops the blood supply. The mechanical stretching of skin, it thins it out, tears it. It can cause full thickness skin necrosis, and it really does affect the way the surgeon can operate on a broken bone. And it gives you bad outcomes. So this is acute. This is a rugby injury, a dislocated knee. It looks ugly, but realign it. Pull on it. Get this straight. That skin is going to do really poorly over the medial aspect of the femur. What about the neurovascular bundle? Imagine the nerves tenting over this forearm and being stretched and compressed. And you'll find this about 2 kilometers from here on the Cascade chair, a teenager with a huge dinner fork deformity, and guys going, whoa, whoa, leave it alone, leave it alone. Well, it just takes time. It takes time to package them. It takes time to get them to the hut. It takes time to get down the hill. And even more so if you're out on a hike and you're in back a temple and you're just out towards Skokie and you slip in some wet rocks. That rescue is going to take time. Even your simple Colles fracture over on the right. Imagine what's happening to that median nerve that whole time out sitting as a dinner fork deformity. It's getting squished. So, tenting of nerves over deformity can produce neuropraxia, and prolonged tenting can cause axonal death. You can leave them with a permanent deficit. In dislocations, prolonged traction on the nerve causes local neuroischemia. So, classic one is the dislocated shoulder. So you get a guy out in the backcountry that has a dislocated shoulder. Get you to wiggle your fingers, wiggle your thumb, everything looks good. An hour later, ooh, I'm feeling some numbness tingling in my fingers. I'm feeling some changes happening because it's still out. Haven't dealt with it. You've just packaged as is and are slowly looking to evacuate. Well, we had a case, again, at one of the local ski resorts where this is a 49-year-old guy who had a dislocation and it was not attempted to reduce. Just by the time it took to get from the ski hill all the time, he was left with a permanent suprascapular nerve palsy, and as a permanent, you can just see wasting of the suprascapular muscle, infrascapular muscle, all those rotator cuff muscles were done because action wasn't taken. So that is an argument for consideration of realigning and reduction in the field.
How long was it?
It'd be about that one of the 50-year-old man, because he likes to talk about it, but it would have been about 4 hours for permanent damage, and that's just it actually again was Nakiska to the Foothills Hospital. It just took that long from time on snow to, and it's a few years ago, but that's the real scenario, and those are the real outcomes. And sometimes when you're in primary response, you don't see that. You don't see the outcome.
Was there any serious deficits with that?
He's still, no, initially intact, and in fact, if you go and read the patroller's reports, it was intact, and then started describing symptoms after, and in fact, more than a suprascapular nerve, he's had actually persistent whole brachial plexus symptomatology from just that prolonged tenting and traction of the nerves. Yeah. So, what about arterial and venous obstruction? Again, that forearm we showed. It leads to swelling distal, ischemia distal to the deformity, can lead to muscle necrosis, increases the chance of compartment syndrome. And also, when you get ischemic muscle, then metabolically, you get a sicker patient. So by not doing a realignment, you're actually making a sicker patient in the overall. They get more acidosis, myoglobin. It can give you all sorts of problems when you're looking at, oh my gosh, where's that threshold to pull on it? We often think just of the fracture in bone, but remember that huge soft tissue envelope around our bones. So all that muscle, all that fat, all the lymphatics, by being deformed, is compromised. What about bone? So, a dislocated hip out in the field, and we had a classic one out in Yaha Ranch that I'm going to show in my cases. You can get avascular necrosis. You can actually cause the femoral head to die by not treating, by not attempting to treat. Talus is another one. What about the actual joint itself? Well, this is a pretty damaged joint from a dislocated knee. And the likelihood is the majority of that articular cartilage was damaged in the moment of the injury. But having it out of joint, having it perched, having the articular cartilage being compressed and depressed kills cells. And you're increasing the chance of osteoarthritis. What about pain? Pain is something often underrated and neglected in managing people in the field, and having something realigned can make a huge difference in pain control. I'll see if I can get this to... No. Yeah, it's all right. It was just a picture of that guy with a dislocated kneecap on the soccer field, hammering his kneecap just instinctively to get it back in. And then the sense of relief when it got back in. So pain is a traumatic experience. It can really change your outlook on how you use a limb, how you behave from then on. It can really influence the long-term effects of trauma. And managing pain, on the other hand, can significantly improve outcome and how someone behaves and how somebody goes with a traumatic experience. Having pain can cause these regional pain syndromes, that can linger for years. What about best in pre-hospital care? What about the concept of us working as teams and giving the best care to our patients? Managing pain is a big part of that, and we're definitely behind on that. Hemorrhage. I think it's pretty well known that in our large bones that shortened large compartments and deformity causes more intervascular bleeding and can change the difference of that critical hour. I think of the trauma that occurred in the Esplanade this year. It was definitely a traumatic death, and time was a huge factor in the long bone fractures, multiple long bone fractures, and that golden hour just didn't happen. So just being on it and reducing and realigning and adding traction. So why did we come to this? Why did we come to the point where there has been, or who, tell me, show of hands, that there has been some reluctance in the field to reduce and realign fractures? Has anyone got that in their brain, that there's some reluctance?
Alberta College of Paramedics.
Yeah. There we go. So the myths of why to realign or reduce. Oh, I'm going to do harm. That's one big one. I'm actually going to be doing harm and realigning a fracture or dislocation. The risk of legal action. I'm going to get sued. I don't want to even enter into that. The need for a highly specialized skills. You know, I gotta definitely be ultra trained in something unique. These are all kind of roadblocks to initiating it. The risk, I'm going to do damage to the nerves and arteries in the realignment procedure. And that I'm actually going to increase the pain in realigning. Oh, I don't want to touch him. He's going to be sore. So I'm going to say that the truths of realignment and reduction. The energy that occurred at the time of the trauma is when the vast majority of damage is done. That damage to the articular cartilage, that, you know, the damage to the soft tissues, the actual energy is so much more than pulling on it. Just think of someone crashing on a ski hill at 30, 40K an hour. The amount of energy is way more than any sort of traction. Pain is reduced. Sorry, I'm going to go back again. I shouldn't have jumped on that. Pain is reduced after a joint or a fracture is realigned. You may have a moment where there's increased pain during the actual procedure. But I can tell you, if you start doing some of the things we're going to talk about here in a minute, doing visual analog scores and asking patients pain pre and post, there's a dramatic decrease in pain, and that overall dose of pain, pace of pain over time. So it is a good thing. Legal action is extremely rare. If you get consent from the person in the backcountry, person in the wilderness to realign their limb, the chance of legal action is really rare. Inline traction techniques are principle-based, and they really are straightforward. You don't need to be highly specialized or trained in this. It's just simple inline traction. Yes, you can gain experience. More experience you are in the field, the better you're going to get at it, but they aren't difficult principles. Again, neurovascular injury occurs at the time of the fracture. Very rare would occur during realignment. So, why realign? Decrease the morbidity in the skin, nerves, arteries, veins, muscle, tendon, bone, and cartilage. Decrease distal ischemia, decrease blood loss, decrease pain. And we're in the pursuit of best pre-hospital care. You know, you go to Europe, you go to Austria, Switzerland, and see some of their teams at work in their pre-hospital care. It's a pretty impressive what they do, the whole package, from analgesia to reduction to, you know, just their packaging and transport. We can improve. So, what are the principles of managing the deformed fracture and dislocation? So, an assessment. Just like anything else, don't let a bad fracture or deformity distract you from the ABCs. So that's a no-brainer. Stick with your ABCs, but then when you've dealt with that, you know, look at their neurovascular status to as best you can. You know, honest, winter scenarios are difficult. Ski boots, difficult to get that in the field, and it's often better to keep the ski boot on, so you won't have all the information. But if you got in the back of your mind, you know what, I have such a low risk of damaging a nerve or an artery that it's actually all the positives of realigning far outweigh that. You know, if you are in the middle of a glacier somewhere up there, I wouldn't get their boot off. I'd leave it on, realignment, and be pretty convinced that you're actually doing well. It is nice if you get a pre-reduction and a post-reduction pain score. Hey, 1 is no pain, 10 is the worst pain you've ever had. What pain are you in? I'm in a 9. Post-reduction, 1 and 10, what are you at? I'm at a 4. It's really good to do. Explain to the injured person what you're going to do and why. I'm doing this because I think this is going to be better for your whole limb and better for your joint and all of that. Explain why. So, people often come up to me and say, how hard do I pull on this limb? Whether it's a forearm, a shoulder, a hip, a knee. And here's my answer. The force of pull is dependent on the site of the fracture. So the hip and the shoulder are going to have more force than the wrist or the elbow. The further out you are, you're going to really need less. The size of the patient. How big is that guy? Is this guy a big bodybuilder? And the experience of the first aider. The more you've dealt with limbs, the more packaging you've done, you tend to get more comfortable with applying traction. And I really do invite anyone to come and visit us in the OR, especially if you're involved with a trauma case. And we get you into some greens and come in and see how we handle limbs under anesthesia. And we do, and we pull hard. It's the first thing we do, and water ski hard. So it's kind of a nice thing to do if you have a scenario to follow them through, from your ambulance to the OR and see what it's like. Yes, encourage your patient to relax. Getting their confidence and getting them to buy in makes a huge difference in how hard you have to pull. Analgesia. And I'm talking the whole spectrum, whether it's Entonox from the ski patrol shack to propofol to that, those are all going to come into play. It's just, it needs to evolve, and we got to get some good protocols. But we're getting the fentanyl lollipops. We're getting a bunch of things that are starting to be available to us. And with some common sense and monitoring, I think analgesia in the field will grow and will become an important part of wilderness medicine and first aid. How much force? Well, the amount of force that's necessary to realign the deformity. That's the answer. How hard do you pull? Till you can get it somewhat realigned. And then this one in red is super important. Sometimes you just won't be able to straighten it. Sometimes that shoulder won't go in, or that fracture, the pattern is just going to be a pattern that as soon as you take any force off it, it wants to deform again. And give yourself permission to say, okay, pulling for 5 hours isn't needed. You can say, we're going to have to package this one as is. So that's an important principle. All the principles that you guys probably know better than I do in packaging. Splint the joint above and below. Slightly elevate for transport. Get edema, lymphatics going in the right direction. Analgesia. Cooling is good for soft tissues. Cooling does decrease the metabolic rate. You don't want to get frostbite, but if you are able to, and you have to assess the whole patient, you wouldn't necessarily throw ice and snow on someone who's hypothermic. But it is good for tissues to use ice and snow. It depends on the wilderness situation, but if you can get help within a day, it's good not to feed them. I think if you are on a multi-day trip, you got to feed someone. But just remember in the back of the mind, if they actually are going to go for surgery, it's just one more roadblock for anesthesia to have a gut full of food that they can aspirate if they need a general anesthetic. So that's something that sometimes doesn't cue in the back of the mind. Yeah.
A point that I'd like to bring up with a lot of people that start out in it with, you can't give them anything by mouth kind of thing. And they're not told it's because of the surgery, etc. But we can be giving people sips of water and stuff if their mouth is all pasty.
Yeah.
It's just don't fill their belly because of the surgery.
Yeah, don't stop at A&W on the way in and have a Big Mac or whatever. Yeah, no, and you know what? If you're on a canoeing trip and there's a fracture and a person's shivery, give them some warm tea. And you know what? Even feed them. If you say, this guy is energy down, they're low, that their whole system takes priority. But we just do see quite a few times someone out ice climbing and they've had a fractured dislocation of the ankle, it's been reduced, and then they do get a tray. We've had them get in a tray in an emergency department, you know, and so it's just something in the back of your mind.
Still recommend reduction on short transport time, 5 minutes up the trail on Tunnel Mountain, or...
Yeah, so I've got a whole slide on that, but the short answer is yes. You know, 5 minutes up the trail on Tunnel Mountain, you know, if you're on scene and it's a twisted ankle and it's off to the side, even that transport time for 5 minutes on Tunnel Mountain is probably going to be a half hour to get someone there, or to you to get them to hobble down to a car or flag a car down. And having that realigned and positioned and splinted is going to be a good thing. You know, there are situations where it's going to just be that much practical to go straight to the emergency department. I don't doubt that. But in general, giving an attempt to get things straighter is probably a good thing. And I will not draw a line in the sand saying all should be done. We're all going to use our common sense too. And sometimes practically it's, hey, let's just wander over and do that, you know, at the hospital. Usually it's a two-patient thing. One first aid patient stabilizes the patient, one does inline traction. And it's simple as pulling in the direction of the deformity. So where it's crooked, start pulling in that direction, and then start bringing it back to a normal or anatomic position. Slowly increase the force. It's not a jerk. It's a slow increase in force and in a graduated manner, and keep getting feedback. Is it straightening? Is it moving? Keep telling them to relax. Good eye engagement can make a huge difference. We get a bunch of what ifs. Well, what if it's broken, not dislocated? Or what if it's a fractured dislocation? I'm going to be honest with you. A deformed, fractured shoulder, what are we going to do in the OR to set things up to go in and get the anatomy straight so I don't cut through the axillary nerve? I'm going to pull on it. We're going to pull on it and try and realign it prior to surgery. So, yeah, if you get crunch, crunch, crunch when you start pulling on a shoulder, you go, okay, we're likely dealing with a fracture and possibly a fracture dislocation. I'm not going to do this for 15 minutes. I'm going to ease off and package them. Yes, they probably have a fracture. So some common sense and get those cues. And you're right. The older the patient, over 50, the more likely you're going to have a fractured shoulder than a dislocated shoulder. Some of the common sense things. A broken hip versus a dislocated hip. You know, definitely we're brittler as we age, and we're more likely to dislocate when we're young and break when we're older. It's the same management, though. It really is the same principles. When they come into emerge, we're going to pull on it. What if they're a kid? What if it's through a growth plate? A lot of people have concern whether this is a dislocation or a fracture or whatever. Well, the actual truth is this shoulder, we're going to pull on. That's how you reduce it. And, you know, appropriate force, but a real deformed shoulder with a spike sticking out there, and we see them, give it a try. Give it a just inline traction, reduce it. Doesn't have to be perfect, but it's going to be way easier to transport them. So, same management. Children's fractures are also managed with inline traction. Those big, huge dinner-fork deformities, you pull on it and get it somewhat straight, the child's going to be happier, the parent's going to be happier. Yep. That's great. Oh, yeah. If you were a bone end, where would you rather be? Out in the cold environment or sitting around moist, nice, warm, serous fluid and hematoma with a bit of oxygen there keeping you alive? Which one? Yeah, and what if you're dirty? Give it a little wash off, put it back inside. Because I'm going to tell you, I'm going to take it out and wash it again, and wash it again, and wash it again. That's compound fracture management is scrub, scrub again, scrub again, scrub again. So I'm going to look after the bugs, but but you're going to have better outcome with that bone under the skin. It's funny you say that. What if? Yeah. So what if you got the femur coming out of the leg? Yeah, the best thing you can do is try and get it packaged under the skin. Kevin?
For just another thought, this one probably not necessary, but I've seen a couple that emerge that were open and splinted, and 4 hours later when they get through our triage and our waiting room stuff, we find that out. That's too late to find
Right.
out. So reduce it as you're discussing, but probably document that
Yeah.
that was done.
Yeah. Yeah, communication.
That needs to get to you faster than
Yeah, no, and that's a good point. Communicating an open wound is pretty darn important. And I'm going to be honest, even if it's just a little trickle of blood coming out of the skin, it's a compound fracture, and we're going to mobilize our team quicker than if it's closed. And so that's a really good point, that communication right through the care.
Do you have an analogy of choice? Like, or if you're, let's say you head out to the bush, you can take one. Which one do you like?
Okay, so in my kit, I actually take two. I actually take a bunch of Percocet, because if you're on a traverse or a backcountry ski trip, it's nice to temporize till maybe a snowstorm blows over and you can get a helicopter in. And the other one I actually take is morphine. And I give it IV. So I got just a little syringe, a needle, and it's stable, and it doesn't seem to be degraded with the cold, and it can sit in your kit for years and years and years. And that's maybe the era that I've been trained in. And as opposed to fentanyl or something like that, which is fairly short acting, it'll give you some length and it'll give you some time. But I'm going to be honest, I am certainly not an expert in pre-hospital analgesia. So I'd be happy if anyone has more expertise to say what's the latest and what's the greatest out there, because I am not an expert in that.
You mentioned pediatrics earlier, and I'm just wondering if you've got an opinion on how young is too young to realign a fracture dislocation and feed.
I don't think too young is an issue. If you've got a totally bent leg in a toddler, and straightening it is a good thing. Yeah. Yeah, I don't think that's an issue. Yeah.
Looking at that picture, do you realign that?
Yes, absolutely. Absolutely. I'd wished, in my first aid kit, I wish I had some gloves. And I'd get someone to pull on it, and I'd at least try and get that end of femur, that femoral diaphysis under the skin. I think that would be a good thing. And I'd be honest with you, if I was really in the wilderness, I'd even take cut the skin to do that. And then throw in a couple of stitches is even okay. Just some real stitches to keep that in a good environment. If I was out in the backcountry, in the wilderness, that would be appropriate thing to do. Here and then there.
As a doc, putting that back together, if there's chunks and such, are you wanting those in the bag?
Yeah, I think so. I'm going to be honest with you. If there's chunks of cortical bone that are out and contaminated, they likely will be discarded, and we'll likely use clean bone graft. Most of our centers have bone banks and bone grafts, so a dead cortical bone with horse manure on it is not as good as clean cortical bone, because the bone dies pretty quickly. The actual cells in the bone that dies. But I think the concept is the same. Whether it be a tooth, whether it be a chunk of bone, I think bring it in. Yeah, we actually just had about a week ago an enucleated talus, where the whole talus was spat out of the ankle in a fracture dislocation of the ankle, and it was brought in on a tether, and right away, before X-ray, before anything, that talus was shoved back in, just forced back in, and it was a good job by the emerge doc. It was impressive to not see an X-ray of it. It was impressive to see it reduced. So, if you can, reduce it under the skin if possible. That's the best thing for the soft tissue envelope. A quick review, the algorithm: assess the neurovascular status, apply inline traction to reduce the deformity, reassess the neurovascular status, Address open wounds. If you can clean them with a little water, great. And then some moist dressings on top. Splint appropriately. And if able, maintain inline traction, especially for those femurs. There's controversy about the tibia. I accept that. I actually am a fan of maintaining inline traction. I think it's just a good thing for decreased pain, keeping the neurovascular envelope as aligned and anatomical as possible. So especially in that large bone, and especially in that femur, it's nice if you can maintain some traction.
Yeah, I read a lot recently about like the process of strong knee traction splints around the ankle.
Right, yeah, so there has been some controversy about the actual traction device being hard on the skin, being hard on the soft tissues, where it sits on the condyles. And so I think some common sense is in order, but I'm going to give you a case here where I think maintaining some inline traction is a good thing. So it is a good question, and there'll always be controversial pieces of equipment and controversial actions, but I think if you defend yourself by saying, what is the best in this situation, it's going to be hard to go wrong. So this was a 40-year-old ice climber back in the lake. These are real cases, so these are really what happened. Deformed lower leg after a call. So he was wearing a mountaineering boot with crampons and had a significant deformity above his boot. The visitor safety specialists got in at dusk, and they couldn't get a helicopter in. And he was on a serial ledge of ice. So in actual fact, trying to evacuate this guy at night wasn't going to work. So this was just after I gave this talk, and a couple of guys said, okay, let's pull on it. So they kept the boot on, they pulled on it, they actually put some skis, and or I think it was skis, in as a splint, and the guy's pain went from 10 out of 10. They bundled, packed him, kept him out overnight, and the number one message he was saying to me as we were going into the OR the next morning is, if my leg wouldn't have been straightened, it would have been the worst night of my life. And when it got straightened, my pain went from an 8, 9, 10 out of 10 down to a 3, 4, and my night was harder dealing with cold than it was with pain. So it was great to see that happen, and what a change in behavior it gave to the wardens. They were so excited by the change that happened in this scenario. This was another true case. 20-week pregnant female out at Yahatinda Ranch, a ways away. Falls off her horse, her hip is out. She's about 24 years old, and there you are. To get back to the ranch, to get a radio call in, to get a helicopter out is going to be hours. They had 2 rescue personnel, and it turns out the 20-year-old gal was a physician, and she talked these guys into reducing the hip. She said, come on, pull on it. And sure enough, got that hip reduced, and it likely saved her from getting avascular necrosis and a total hip in her 30s and 40s. So that reduction in the field was really jogged my mind. It was in the 90s. It was a long time ago, but it really imprinted in me the good of doing that in a real remote setting. Here is one. Ski touring at Bow Hut, compound tibia fracture. No evacuation until the next morning. And so this is one where I actually saw the negative. They left the bone out, they packaged it with gauze, left it deformed, and got out the next morning, and they got deep wound infection, some osteonecrosis and osteomyelitis at the fracture site, needed that fracture cut and take away. And so I just asked myself, if they'd been able to get that soft tissue, that bone under soft tissues, might that change the long time? So that one imprinted in my brain too. And again, I want to go over that pro and con reduction. So this winter we had a dislocation at the Lake Louise, and they tried on the hill to reduce it. And let's say it happened at about noon, and then they got down to the medical clinic, again no x-ray, and then they actually tried for about 3 hours to reduce it. and initially neurovascularly intact, but it definitely was out, and didn't get in till about 5 hours later, and by that time had a brachial nerve palsy, just had a significant deficits that actually resolved quite quickly, but it just went in to tell me that versus the guy who had no attempt at reduction and had a brachial nerve palsy because nothing was done. There is going to be a time that after pulling on something, you got to say it's not going. Not all fractures and dislocations are going to be realignable. So you just have to, with some experience and some common sense, to say enough is enough. Now I have to admit, if you're out at Bow Hut and there's a blizzard and someone dislocates your shoulder, I just hang them over the table for a good period of time and see if just some gentle inline, tie a bucket of water around them. I remember twice here in Emerge getting called by the Emerge docs, which are great at reducing, and said, well, I'm going to drive in from Canmore, but in the 20 minutes I want you to just hang them with a bucket of water over the edge of the table. And both times they reduced while I drove back in. So that long sustained traction, if you are caught off in the middle of nowhere. But you also got to know there's times when to say enough is enough and it's not reducible. But there's also times to know you can do some bad stuff if it's 4 or 5 hours to care without trying. So we do have a bit of a dichotomy, but I'm going to encourage you to at least attempt realignment and reduction. Well, implementation. Jay kind of hit the nail on the head. It varies with jurisdiction, and it also varies with what hat you're on. There's times, I wear a physician hat. There's times where I was wearing a ski patrol hat. There's times when you're just a trip leader or a trip member in the backcountry. You have different hats. But I think if you can think of some teamwork and some communication to implement these things, you don't work in isolation. That you have some support and work with your hospitals, work with your paramedics, work with the whole number of layers to get some relationships going. Look at your response and transport times. Are you 5 minutes away? Are you 3 minutes away? How experienced is your team? Are you in an area that gets lots of trauma? Or is this something that happens every few years? It's going to change what you do. Start with some frequent injuries. I actually think shoulder dislocations in our area is a great one. Fractures femurs and tibias. These are good ones that should be straightened. We see them routinely enough, and the differences that can be made is great enough that I think having some algorithms to follow. Monitor pain score. Just 1 to 10. How do you feel before and after? Catalog your adverse events. And then work with your local group. So we did implement this with our rescue wardens, and it's been super positive. We've had really good feedback, and they are now, more and more attempting realignment in the field, and they're more and more buying in. I had a lot of resistance when I started giving this basic talk about 5-6 years ago. Now I get it. I think this is the best in pre-hospital care, and other guys are getting on board. Analgesia, not that I'm not strong in it, but we got a couple of guys that are Kyle McLaughlin and a few other guys that are more expert in that. Some of our anesthesia staff are more interested in analgesia. So that's what we've done. We've actually introduced it to the ski patrol, and my time is up. And I want to just thank you for inviting me to talk. And is there any other questions?
Any suggestions for if analgesia is not available for getting someone, say, with a dislocated shoulder, just prevent them from guarding and keeping their muscles tense?
You presenting yourself with confidence, eye-to-eye contact, and continued dialogue, and continued let it go, relax. This is going to go in better if you don't fight me. And that presence, that communication, and that whole principle of a graduated traction, so you don't start super hard, you start really slow, gradually increase it over time, gradually get their trust. And in that scenario, if you really are in the backcountry, time is a bit on your side because they fatigue. All of a sudden they start getting muscle fatigue from being in spasm for so long. So in a real wilderness situation, you know, you can consider just that inline traction for 20, 30 minutes.
Along those same lines in a non-analgesic environment, something along the Cunningham technique, you can sort of get trained along that. Is that something to work towards?
It sure is. So that's where you start wandering from the basic principles and get more training and more experience. And I kind of kept this talk simple to inline traction, but I'm certainly not adverse to learning other relaxation techniques, the trap pinch, and there's that Australian one, the Cunningham one, and there's a bunch, and learning those and getting practice in that, I have no problem with that.
Do you feel there's any risks associated to inline traction?
You know what, I don't. If you come with a fracture or dislocation in the OR, you'll see how hard we pull, and you know, is there a 1 in 10,000 chance you're going to pinch a nerve or an artery? So if you got a pink hand and you straighten it and it goes white, deform it again. Well, I mean that. But in 25 years, I've only heard stories about it, and I've seen thousands of fractures. I've never actually seen it. I've seen torn arteries, but it's all occurred at the time of trauma. The motorcycle on the road, the really nasty one. I've seen neurovascular deficit, but it's almost always been traumatic. Yeah, so I'm not seeing that.